I will be talking about the differential or the lack of differentiality between neuropathology across diagnostic boundaries. I will tend to restrict myself to talk about mainly psychosis, but I will give you examples of other disorders. So since most of our research in my research team is based on early onset psychosis, I will try to focus on that, but I will also give you examples of other disorders. So this is what I will be talking about, a brief introduction. Then I will try to convince you that it's all about developmental trajectories, not static pictures. So we are too used in psychiatry to see one patient and see what we have in front of us. And you know, sometimes we go backwards, but we go backwards until, you know, when all this started, or we go backwards until the patient was 18 or 16 or 14. We hardly ever, when we see an adult patient, we hardly ever ask about how was this kid in kindergarten, how was, you know, any changes during development as compared to the siblings, as compared to other peers at the school. Things that I do believe are have extraordinary clinical relevance and importance in terms of assessing the patient. So I will try to convince you that this is an ongoing process that starts with fertilization, and you know, but by the end of adolescence, if not all the damage, but most of the damage is already done. And then what are the implications for prevention of this theory and this paradigm? So many of you will be adult psychiatrists, and you will be treating only patients above the age of 18. But if you look carefully, it's going to be difficult to find one single patient with anxiety disorder, for instance, with depression, with schizophrenia, with bipolar disorder, that did not have some signs or symptoms during development. And in this nice review published in Nature Neuroscience some years ago, it's stated that around 70% of all psychiatric disorders emerge during adolescence or before adolescence. And this is something I think we need to keep in mind. And for impulse control disorders and for many of these personality disorders, you know, symptoms do not start with adulthood. Don't start, you know, all of the bloom at the age of 18 or 20 or 24. They're present there, but they're present with a sub-threshold that does not allow us to make the diagnosis. And this will be the case for other disorders like mood disorders or anxiety. And the truth is that when we compare the field of psychiatry to the field of our sister neurology, one of the major differences between psychiatry and neurology is the mean age of the patients that we treat, or at least the mean age of the age of onset of the patients that we treat. And our colleagues in neurology tend to see patients whose disorder mainly start in adulthood or late adulthood, all these neurodegenerative disorders. Meanwhile, we tend to see patients whose disorder started at least at the symptomatic level in childhood or adolescence. So that's why you have here in yellow mental disorders are really overrepresented between the age of 10 and 20 as compared to all other disorders in medicine. But most of the action takes place very early. And by very early, I mean even in utero, in terms of how the brain develops. And you know, we cannot say that the brain is mature and it doesn't change after the age of 20 or 25, because that's not true. And we see changes taking place in all our life, and we even have neurogenesis. New neurons are created when we die at the age of 80. But still, the plasticity and the major changes in how the brain is configured take place in utero or very early after we are born. And in fact, you know, when we are 4, the size of our brain is double when we're born, and that's about it. We start losing gray matter after the age of 7, and white matter increases until the age of 20, 22. But no much action, although some action, which is important, and I will talk about that later when I talk about epigenetics, but not much action takes place after that. So all these proliferation, migration, arborization, and myelination takes place in utero, and then continues. And this is a paper by Tom Insel published in Nature some years ago. So this is age 5, 10, and most of the brain is already formed by this age. This is a quite provocative paper published in European Child and Adolescent Psychiatry last year by one of my colleagues. Why psychogeriatrics starts right after adolescence. So, you know, you go from adolescence to psychogeriatrics. And the main message from this paper is that it's not only that most of the brain is formed early in development, intrautero or in childhood or early adolescence, is that there are also some windows of development. And if we miss those windows, then there is no much room for change. And this is easy. I'll give you two examples. One example is hearing, another one is the vision. So there are some windows in which if the child does not see, then that function is lost. It doesn't matter what happened afterwards, it cannot be recovered. And the same will be for hearing. So it's not only that it's most cost effectiveness to intervene in childhood because the brain is more plastic and it's easier to change. It's also that we may be missing some windows afterward, and after these windows, the changes in the brain are difficult to achieve. So, for many years now, we have been hearing this neurodevelopmental hypothesis for diseases like schizophrenia that I also do believe applies to many other disorders, not only schizophrenia, in which the brain undergoes changes in its development, and this leads to symptoms many years later. So this is one of the big questions in psychiatry is why neurodevelopmental disorders do not show up at the very beginning. Autism is clear. Many times we can diagnose autism at the age of 12 months. If it's not severe enough, 24 months. It's Asperger's, maybe 5, 6, 7. But it's there from the beginning. Why some of these neurodevelopmental disorders do not show off in a clear way? I mean, if you scratch enough, if you look for it carefully, most of the times, not always, but most of the times you will see something there, and I will review that data with you. But that's one of the critical questions for these neurodevelopmental disorders. So this neurodevelopmental theory applied to schizophrenia is not new, and Emil Kraepelin mentioned it in 1920. So he says that the question is raised in what relation the psychopathic abnormalities, which with striking frequency precede the developmental of dementia precox, stand to the later disease, and especially whether they are only the expression of constitutional injuries. So here, he's talking about these intrauterine insults to the brain, which lower the power of resistance, so make the person more vulnerable to environmental factors later that will produce what he called dementia precox. And not only that, but he mentioned, nowadays that staging is so commonly used, and there are groups out there with Pat Montgomery leading the field, talking about what good is to stage disorders in the way in psychiatry, the way we do it in oncology and in other areas of medicine. This is what Emil Kraepelin also mentioned many years ago. Various development stages of mental disorder correspond to the gradual extension of a morbid process through more and more areas of the brain. So, he already had in mind these staging processes that some point in time, enough brain is affected that it is expressed in the form of delusions or hallucinations. But we can go even farther back, and we can go 2,000 years ago. And this is a quote from the Yellow Emperor's Classic of Medicine, where it says, "People are born to have the illness of craziness. How does it come about? It is an illness started in the womb, in the uterus, resulting from a bad scar of the mother when she was pregnant. So already this book, written 2,000 years ago, is pointing to problems in how the brain develops in utero, and that's the cause of what is called here illness of craziness. So this is, the question which is, we all face in why do these neurodevelopmental disorders start at the age of 14, 16, 18, 24? The answer will be, the easy answer will be is that it's not up until some areas of the brain are mature and are called into action that we can assess its abnormal functioning. So there's no way we can assess language in a 1-year-old kid because there is no language. So we cannot assess it. So some areas of the brain we know that, dorsolateral prefrontal cortex, areas related to working memory, areas related to meta representation, finish their maturation late in adolescence, and that may be the reason why we see the problem there, because that area was not mature. And it was not called into action. So there's a new field. It's not new, but has been there for 10 years approximately, and about early intervention in psychiatry. And I do think that this is the way forward, and this is the way to go. And rather than trying to change things when it's too late, and with chronic patients who have been sick for 20, 30 years, for sure we can do many things for them. I'm not that sure that we can change the course of the disease at that stage. We know that many of the risk factors involved in schizophrenia have to do with how the brain develops. All these infections and prenatal problems, obstetric complications, they affect how the brain matures, and they increase the risk of having psychosis or schizophrenia. So that was the introduction, and now it's time for me to try to convince you that it's all about developmental trajectories. And by developmental trajectories, I will try to convince you that we don't have a genetic risk factor for schizophrenia, or we don't have an environmental risk factor for schizophrenia or for bipolar disorder, or we don't have an interaction of those risk factors, genetic and environmental, for a given disease. What we have are risk factors for abnormal ways of how the brain develops. And that abnormal development will end up showing some symptoms that will allow us to classify patients with the diagnostic criteria, the artificial diagnostic criteria that we use nowadays, because we need to put all these patients together. But my belief is that patients that do have some of these disorders have hundreds or thousands of different pathophysiologies that have to do with genes that sensitize or code for abnormal proteins that make the brain abnormal. And the brain has a restricted way of expressing that something goes wrong. And with depression, with anxiety, with voices, and that's why we cluster artificially these abnormal developments in a way that is not going to be very informative for future research. And all this has been because we in psychiatry have been too much focused on static assessment of our patients, and we have not taken into account the dynamic perspective since birthhood. We know that mental disorders, including schizophrenia, bipolar disorders, depression, others, are complex disorders, and we have one gene from one disorder. We have, these are polygenic and genetically heterogeneous conditions. There is a lot of evidence from genetic studies with many SNPs that have been identified. Many of them have to do with proteins that are relevant for neurodevelopment. So the function of synapses, migration, myelination. So when we see in these association studies or GWAS study, many of the SNPs identified are related through the proteins they express with neurodevelopment. But this is not something that is terribly specific, because we know we have 30,000 genes approximately, and of those 30,000 genes, we have 2/3 of the genes have something to do with how the brain develops. So 2/3, 20,000. So all these SNPs have a very small effect size. But we do have another ways to assess the genetic risk for some of the disorders. And I think a nice example will be disorders for which we know which is the genetic abnormality. I ran a clinic for 22q11 disorder in Madrid. So I have like 70 patients with 22q11 that I see every Wednesday in the evening in my hospital. And having seen these patients for many years now, I can tell you that they are completely different. Many of them have psychotic symptoms, up to 50%, mainly auditory hallucinations. Up to 20, 25, 30% will end up fulfilling criteria for schizophrenia, but they have many other disorders. So even in the case, what happens with 22q11, in which we have identified the genetic abnormality, this single genetic abnormality will express itself in many different ways. And many of these kids have ADHD, they have depression, they have anxiety. So this is telling something, and this is called pleiotropy, in which one single abnormality expresses itself in many different ways, and this is probably telling us about the importance of the environment in how this single genetic abnormality expresses itself. So CNVs, which are very relevant nowadays, probably they explain a small proportion of the patients that we see in our clinic, but it's increasing. And up to 20% of all cases of autism that we see nowadays have a CNV which is clinically relevant. So I think these are very good models in which we know what is the etiology, and we don't need to go from the symptoms, which is a long distance, to the etiology. And from knowing the etiology, we can study what is the pathophysiology that ends up producing those psychotic symptoms. So this is what I told you. These deletions, 22q11, will express itself with schizophrenia, epilepsy, autism, mental retardation, birth defects, and the same for others. So single genetic abnormalities will have pleiotropy, and depending probably on the environment and the expression of different and the expression of other genes will produce different psychiatric conditions. This is an interesting paper published this year in Nature by Stephenson, Andreas Meyer-Lindenberg, and others in Iceland. What they do here is they compare the general population in Iceland in black, and here in green you have general population with CNVs that have not been shown to be clinically relevant for autism or schizophrenia. They compare them to patients with schizophrenia, here in red, in cognitive assessments. All these are cognitive battery tests. And what they see is that general population that have CNVs that are relevant for autism or schizophrenia fall in between. So these are normal people, do not have schizophrenia, do not have any mental disorder, but they do have the CNVs that have been shown to be related to schizophrenia and autism. So these CNVs are probably there without producing psychotic symptoms or without producing psychiatric symptoms. And I do believe that the study of these CNVs that have been shown relevant for mental disorders will shed light in the future about the pathophysiology of some of these, at least cognitive conditions. So I wouldn't have the time to go over the vast evidence about that schizophrenia or psychosis is a developmental disorder. Many neuroimaging studies in high-risk patients, studies with post-mortem tissues, abnormal migration of different layers of the cortex. So there's something wrong in how the brain develops very early. This migration. We know that stressors, either biological stressors like influenza infections or psychological stressors that may cause increase in cortisol and they may cause brain insults, increase the risk of psychosis 20, 30 years later. So we know that women who were pregnant by the time their husbands went to war, 20, 30 years later, had a twofold increase of having an offspring with schizophrenia or with a psychotic disorder. We also know that fingerprints of when our fingerprints are dissociated, and we have these dermatoglyphic dissociations that the neuroectoderm that is the origin of the central nervous system. One point in time is with the ectoderm that produces the skin. So we're born with these fingerprints that do not change during our life. And patients with schizophrenia, patients with psychotic disorders, and we have published this, do have these dissociations. So the fingerprints are not normal, which is an indirect signal of the brain developing wrong in utero. We also know that many years before these kids have psychotic symptoms, they have premorbid abnormalities, motor, social, educational. We have seen this mainly in patients with schizophrenia as compared to healthy controls. The IQ is also lower. And again, this is many years before. So this is 15, 20 years before they have the first psychotic symptoms. They had the first delusions and hallucinations, and therefore many years before we make the diagnosis. Neurological soft signs, we have also seen this in kids at high risk to suffer from psychosis, and we have seen this retrospectively in videos of kids who ended up having schizophrenia. We published this some years ago. And there's also some very nice cohort studies that allow us to longitudinally assess a cohort of people. This is a Dunedin study in New Zealand that assessed more than 1,000 kids. And what we see in these studies is that there are already motor and cognitive developmental problems by the age of 3. So this is the people who develop schizophrenia at the age of 3, 5, 7, 9, as compared to healthy controls. So the abnormality was already there, although the psychotic symptoms did not show up until many, many years later. And we also know that some of these risk factors interact one with each other, so cannabis and trauma during childhood. The interaction of these has an exponential effect in terms of increasing the risk for developing psychosis. And many of these risk factors are not specific. And this is, I told you that one of the main take-home messages from my talk was that it's about how the brain develops, is dynamic, not static. The second one will be that it's none or at least very few, if any, of these risk factors is specific to schizophrenia, or it is specific to bipolar disorder. So these are risk factors for abnormal brains that may end up showing depressive symptoms, anxiety symptoms, or schizophrenia symptoms, depending on how they mature. And again, I will finish with that has profound implications for prevention. Maybe not for primary prevention, but for secondary prevention, because we may end up having less severe conditions if we intervene early in life. So for a number of years now, we have been conducting studies in adolescents at high risk to develop psychosis, and we have seen that many of these abnormal wiring, either structural or DTI MRI studies, are not specific and cannot predict whose of our kids are going to develop major depression with psychotic symptoms, bipolar, or schizophrenia. So some of these kids who end up developing schizophrenia will have medial frontal, the same as those who will end up having bipolar disorder. So in a recent, and the same will be for disorders such as ADHD or other psychotic conditions. This is data from NIMH, from Judith Rappaport, showing that as compared to the development of normal maturation, kids that end up having some of these disorders, like ADHD or other neurodevelopmental disorders, will have a different way of maturing the brain. And these progressive changes, we believe that do not change when the patient has the first psychotic symptoms. So we have also followed up adolescents after the first psychotic break. And we see that these brain changes, this brain maturation, and this is a mean, the mean age in this study was around 15. So the kids in red, let's focus on the males. Kids in red have lower left frontal gray matter volume, but 2 years later, it was further increased. So they even have less left frontal gray matter. So these progressive changes do not end up when the patient has the first psychotic symptoms and go over at least 1, 2, 3, 4, 5 years after the first psychotic break. Again, this has important implications because we have seen that the more brain they lose after the first psychotic break, the worse the prognosis. So in this paper, IMPRESS, it's not published yet, but it's IMPRESS in Schizophrenia Bulletin, we mentioned that differential neurodevelopmental trajectories in patients with bipolar disorder or schizophrenia may be very unspecific. And as we know that genes do not know about DSM-5 and genes do not express proteins thinking about, what DSM-5 or ICD-10 diagnosis will this patient have, brain trajectories do not know about DSM-5. So trying to study these brain trajectories, clustering the patients in bipolar or schizophrenia or major depression with psychotic symptoms may not be the way to do it. And we suggest that some of these abnormal developmental trajectories are more related to phenotypic features, for instance, very early onset psychotic symptoms, rather than DSM-5 diagnostic criteria. So what are the implications for prevention? Well, first of all, we have to acknowledge that many people out there, and maybe many people in here, do hear voices and have delusions. So this is not talking about extremely badly developed brains that express symptoms of psychotic symptoms of delusions and hallucinations. And many what we call healthy brains may also express these symptoms. We conducted a study with WHO with more than 2,056 subjects in 52 countries, and the prevalence of at least one psychotic symptom varied in these 52 countries from 0.8% to 31%. So huge variation depending on cultural issues, depending on risk factors, urbanicity, cannabis, and so on. So this is important to keep in mind that many of what we call healthy brains, some point in time also produce these psychotic symptoms. So how are we treating in psychiatry nowadays? We treat at the symptomatic level, and we have excellent painkillers, we have excellent antipsychotic drugs that reduce positive symptoms. So we treat at this level. We take a group of patients with a clinical syndrome, either schizophrenia or bipolar, and then we treat without knowing the pathophysiology. But that's probably not the way forward. And we have been very lucky in terms of serendipity, and we have excellent drugs, excellent antidepressants, excellent antipsychotics that we were very lucky to find that they improve our patients' symptoms. But I think we have come to a position in which right now we can only produce Me Too drugs with the same mechanism of actions that will end up with drugs that probably have with different side effect profile, but not a better efficacy. So it's not until we know the pathophysiology or the pathogenesis of the disorders that we will be able to do primary or better secondary prevention. So this is just an example of psychiatry as compared to cardiology, where we were in 1950s in terms of number of drugs with different mechanism of action. This is depression, this is schizophrenia, this is heart disease, and this is now. So we're still in the same position as we were in 1950s, and our colleagues in cardiology are here. Why? Because what they do is they study the molecular pathophysiology, and they come up with target identification, and they test that target identification in animal models, and then they go to clinical trials. And we usually go the way backwards. That has changed in recent years with more or less luck, and we also see, we're all seeing of these phase 3 studies that fail to show efficacy, like the bitopertin, the Roche compound, the glycine transporting inhibitor. But there may be some hope there, and that hope may come with drugs that add at the alpha-7 nicotinic receptor, the glutamatergic, even though it has not been shown in phase 3 studies to be efficacious, the GABA receptor. But these are ways to go, rather than going from the clinical symptom to the pathophysiology, going from the pathophysiology to the clinical symptom. So this would be an example of the GABAergic studies. 2 more minutes. So in terms of prevention, primary prevention may be science fiction, but if we know that some of risk factors, we may be able to prevent them. And most importantly, even if these risk factors are genetic, we may also do primary prevention. And I think this is important. This is a good example by Bob Friedman, published in the American Journal of Psychiatry. So even in the presence of gene mutations, we know that the lack of choline in utero is a risk factor for a developmental delay in inhibition. And this developmental delay in inhibition causes attentional problems. So even in utero, in kids that have this genetic defect, if we add choline, we may help these inhibitory pathways to develop in a normal way. And this is a very nice example of a primary prevention in the presence of a genetic mutation. So the paradigm, how I see it nowadays in terms of prevention, so we can intervene in many different steps. So this would be the primary prevention. So we have people with a maximum genetic load or maximum genetic risk for mental disorders or a minimum that interact with the environment, and we can do it here, as I show you with the choline or many other examples in utero. We can act a little bit later once the gene environment interaction has taken place and after the person is born, or we can do secondary prevention. And this is what we will be doing with conditions such as the attenuated psychosis syndrome, because this attenuated psychosis syndrome in no way is only a precursor of schizophrenia. It's a precursor of many different conditions like bipolar disorder or a major depression with psychotic symptoms. So by intervening here with resilience and risk factors, we may end up with less severe conditions. So the paradigm is that we don't have genes or environment risk factors for schizophrenia here, schizophrenia spectrum disorder. We have gene and environment risk factors for bad brains that will end up producing depression, anxiety, other conditions. And if things really go wrong, we will have these more severe conditions. So this is like, and this is Pat McGorry's slides, this is like being here, you can end up here at this very end, which is really bad because this is the most severe conditions, schizophrenia, bipolar disorder, but you can also end up here with a mild condition such as anxiety or major depression. And this is like pluripotential stem cells. You can have a stem cell, and this stem cell can derive in a cardiac cell or in a neuron. So this stem cell will derive into a liver cell or cardiac cell or a neuron, depending on the context and depending on what nutrients you put, the context of where you grow up, this cell. So these pluripotential stem cells for mental disorders can produce different types of disorders. And I guess, this is important in terms of primary and secondary prevention. So we have the psychosis heart rate state, which may end up in syndrome 3, but it may also end up in syndrome 2 or 1 that will be less severe. And with that, I will finish with conclusions. Schizophrenia or psychosis is a complex disorder that is preceded by abnormal brain development, at least in a majority of cases. The genetic effects of a single gene can be expressed as multiple phenotypic traits, pleiotropy. An abnormal neurodevelopmental genetically mediated can be expressed in many different ways, epigenetics. And what we call nowadays schizophrenia or psychosis is composed by many different etiopathophysiciologies converging in common phenotypic symptomatology. And it has implications for target treatments at different stages: primary prevention for the vulnerability, trying to reduce the vulnerability, or treat the vulnerability once it is present at different stages, or secondary prevention of psychosis. And I would like to thank my research group, and thank you very much for your attention.